So our saving model through Innovative Health was $315,000 a year, which is a significant savings that we wouldn't get from negotiating better pricing with any of our vendors. It's a windfall for the lab. When we transition towards Innovative Health for all of our reprocessing solutions, the first thing I expect to happen is I expect Biosense Webster to do exactly what they did 8 years ago and tell us that they are no longer going to be able to support our cases. If we use reprocessed catheters, then they will not be able to be there for our cases. And my answer to them is we don't need them there for our cases. We have the capabilities to map cases ourselves. Our EP techs are trained on mapping with more than one system, and they have the ability to independently map with the physicians. So I don't really see it impacting our operations at all. I think the reps might be a little upset, but other than that, business goes on like usual. For the most part, we do all of our training in-house. I mean, techs that have no clinical experience and lots of book experience really do need to be trained from the ground up. So we start with sterile technique, and the process takes us about 3 months to get them to the point where they are running a recording system and a stimulator and an ablation generator and starting to do some basic mapping functions. And then at the 6-month mark, they're usually able to get through a case, complete a case. I would say that experience is the most important factor. So really, the longer they do it and the more they're able to do it, they get better and better. But by a year, our techs are usually very independent when it comes to mapping and running all aspects of the EP recording system and stuff like that. It's definitely something that's doable. In fact, once you get good with one mapping system, it's much easier to take what you've learned and adopt it into the other mapping systems. It all really becomes more about interface features. Where are the buttons that I want to do with it? Where did they move it? What's it look like? That's the part that changes between the systems. The concepts are all very similar. It can be applied across the systems. I think long term, they probably could become better than the OEM techs. I justify keeping in-house techs trained and on staff for a couple of reasons. The first reason is that I'm not sure legally that the OEM techs can run all of the equipment in your lab. They definitely should never be delivering any type of therapy to a patient as far as ablation or stimulation. And there's a fine line between them developing ablation strategies with a physician that kind of blurs that as well. So I think you're doing your patients and your hospital a disservice if you're not training your own staff to do everything in your lab. It increases retention of your employees, it keeps them happier, it keeps them more engaged, more involved. I think the second part to not relying on the OEM techs exclusively is that you're a slave to their schedule. They are not at your facility 24 hours a day. They are often covering cases in other locations. They're a limited resource in their areas. And if you have an inpatient that needs an ablation, or you get an add-on through the emergency room, or you have a physician that wants to bring a patient in to do a procedure, it's now whether or not the OEM tech is available that determines whether or not you can do the procedure. And that's not right. You should be able to do the procedure when it's best for the patient and best for the physician, not when it's the most convenient for the clinical rep.